Hello everyone, welcome to CNMST Students Wing webinar series Nuclear Medicine 2020. So finally we are approaching the end of this webinar series. So that's the day 3 of this presentation series. So we are having so far. And after that, we are having one more session by Arapali Joshi Rakesh from IIT Kharagpur. And now I will going to discuss on therapeutic radiopharmaceuticals. So I guess Punita has covered a great content for diagnostic radiopharmaceuticals which are used in clinicals as of now. So I will now dig deeper inside therapeutic part, because now we have diagnosed something. Now it's time to go for therapy. So now if we go and look at cancer therapy as a whole, so this cancer therapy can be of two different types. You can treat cancer by means of local intervention, or you can treat cancer by means of systemic intervention. And in local intervention, you can either go for surgery by accessing the tumor out of the region of interest, and then by means of external beam radiation therapy, you can go and irradiate the tumor of the given region. And by means of systemic therapy, you can either go for chemotherapy or targeting therapy for treating cancer. So now again, if we go and classify radiation therapy as a whole, so that's the branch of nuclear science which aims at treating cancer using radiation. So EBRT, which we call as external beam radiation therapy, I guess those who are from radiation oncology, they are well familiar with this EBRT, Linux, and many more things. Also brachytherapy, and also we can treat cancer by means of systemic radioisotope therapy or unsealed source radiotherapy. And whatever source we use over here, these are all unsealed source, but whatever source are being used over here, these are all sealed source. But if you go and look at conventional radiotherapy, it really plays a great role in treatment of cancer. But that's limited to a specific region in the body. For example, if you have a tumor in this part of the breast, so if you go and irradiate this tumor volume, so you are done with this therapy. But now if the tumor is now spreads from this location to multiple other locations through metastasizing, so it's not easy to irradiate whole tumor in different regions of the body, so that's impractical. So we have to think for some other possibilities. So that's where the role of systemic intervention comes, in which we can treat these widespread mets by using chemotherapy or targeting therapy. And our discussion today is limited for discussing this targeting therapy. We'll discuss only about this part, not on surgical ways of cancer therapy, nor external beam therapy, nor chemotherapy. We are only focused understanding the targeted therapy part. So it all started by the work of Dougherty and Lawrence, and they introduced P32 for the treatment of leukemia. And what is this P32? That's a radiopharmaceutical. So what is it doing? Basically, it's delivering therapeutic doses of ionizing radiation, and it's being used for treatment of patients with leukemia. So now, as I have told before, this P32 is a radiopharmaceutical. So radiopharmaceuticals can be of two different types. It can be an unconjugated radiopharmaceutical, or it can be a conjugated radiopharmaceutical. So what is all about these unconjugated radiopharmaceutical? So this unconjugated radiopharmaceutical is just a naked pharmaceutical. Example, iodine 131, P32, and so on and so forth. So it means that this radionuclide does not have anything in conjunction with it. Fine. But if the radionuclide is a naked one, so how can this radionuclide go and target specific disease? That's obviously the question. So obviously these, as we are calling those as radionuclides or radiopharmaceuticals, and as they are being used for therapy, so obviously they have a specificity for a given disease. For example, if we talk about iodine 131, it targets specific disease by virtue of its chemical, its biological, or its physical affinity for the given location. Example, iodine is taken by our thyroid follicular cells. So that's our thyroid follicular cells, and it expresses a type of active transporting proteins which we call as sodium iodide importer. And what it does, it actually pumps iodine to inside the thyroid follicular cells, and once iodine is available inside, it keep on decaying by beta emissions, and these beta rays, beta particles goes and deposit energy inside this given tumor volume and creates molecular lesions and like double strand DNA breaks, single strand DNA breaks. And what is more important, which we are interested, that's the number of unrepaired DNA damage, which is important for the radiation therapy part of view. So that's an example of molecular radiotherapy in which you are using an radio isotope for treating the thyroid carcinoma. So that's example of the unconjugated radiopharmaceutical. That is, your pharmaceutical is naked. It's not being bound to any ligand, any molecule, or anything else. So now we talk about the next part of the pharmaceutical, that's what we call as conjugated radiopharmaceutical. So what's so special about these conjugated radiopharmaceutical? So in this group of pharmaceuticals, what actually goes that this radionuclide or the radiometal is bound to a carrier molecule or a ligand. It can be anything like small molecules, monoclonal antibodies, polyclonal antibodies, peptides, amino acids. It can be anything. Fine. And this molecule, or which you call as carrier molecule, it decides where this nucleate has to go. For example, over here, this carrier is very specific for the given target. That's like a key and a lock. So this key is specific for this lock, so it will go and bind over here. So what we are doing in case of conjugated radiopharmaceuticals, we are please participant, please mute your mic, please. So what we do in case of these conjugated radiopharmaceuticals, we have a radionuclide and we bound this pharmaceutical radionuclide to this carrier molecule. Fine. And the carrier has a given affinity for this given target. So wherever the carrier goes, it takes away the pharmaceutical radionuclide with it. And once this carrier binds to the target, so it has also the radionuclide. And this nuclide, it decays by beta or alpha, and it goes and kills or damages the tumor cell or whatever it be. That's how these conjugated radiopharmaceuticals work. So that's work in conjunction with a small molecule, peptide, antibody, or anything else, whatever you wish to check with it. So it all started by the envisionment of Dr. Paul Ehrlich, who is an eminent immunologist, scientist, and a Nobel laureate, and he envisioned the concept of magic bullet. So what is all about this magic bullet theory? So that magic bullet can be anything. It can be any drug, it can be any molecule, it can be anything, it can be any peptides or whatever it be. But the main concept is that this magic bullet is specific for a given disease cell or given disease tissue. For example, if we have a given tissue over here and only this cell is infected, so this magic bullet will go and attack this cell only, it will spare remaining cells. And that's the main idea behind this magic bullet theory, which Paul Ehrlich proposed. But that's very initial era, 1800th century. But how could he know about this concept at that time? Because as he was an immunologist, he knows how antibodies, antigens make complexes and how specific those interactions are. He had a great idea regarding those antigen antibody concepts. So that's why he envisioned that maybe antibody can act as magic bullet in the later days, because at that time antibodies, when we had more amount of polyclonal antibodies, we don't have monoclonal antibodies at that time. But he thought that in future we can use these antibodies for using as a magic bullet. And its first demonstration came by the use of iodine 131 level polyclonal antibodies, and these were being used for treatment of patients with melanoma. So what it is, basically we have iodine 131, which is now conjugated with a polyclonal antibody, and that's specific for this melanoma. But although this therapy has a lot of side effects because that's a polyclonal antibody, so it's binding to multiple sites, so we are also getting a couple amount of side effects also. But if he had used a monoclonal antibody, it would not have created side effects. But at that time it was very difficult to engineer a specific monoclonal antibody for a given target, but still they have used the concept of these polyclonal antibodies too. But that's was the initial era at which they used the concept of magic bullet. So these are the group of therapy which we use in nuclear medicine departments. And there are different types of therapy. It can be an oral therapy, it can be systemic therapy, it can be local or regional therapies also. For example, of local therapy includes iodine 131 sodium iodide, and I guess I have explained it before also how iodine is being used for treating hyperthyroidism or thyroid cancer for both local and metastatic disease. And the way it enters entry inside the follicular cells is by means of the active transport via the sodium iodide importing proteins. And apart from these, we also use P32 sodium orthophosphate, and that's used to treat a wide variety of blood-related disorders. Example, polycythemia vera or chronic myelogenous leukemia. So this P32 is being used for treating those group of diseases. And apart from these group of pharmaceuticals like strontium chloride, metastron, or samedium ADTMP, or we call it quadramat, or these group of drugs are being used for the palliative therapy of pain due to bone mats, and these targets the hydroxyapatite crystals of the bone, and which are over proliferated because of the bone mats, and it goes and attacks to those regions which have higher osteoblastic activity, and hence it goes and treat those part and gives you palliative therapy. And now we talk about some special molecules over here. We have iodine 131 trastuzumab or yttrium 90 level. This drug we call as Zevalin. So what is so special about these? So these are the antibodies over here. These are monoclonal antibodies which are bound to the radionuclide or radiometal, and that's what we call as radioimmunotherapy, because we are using monoclonal antibody for treating the disease. Example of these, the target for this group of drugs is the CD20 receptor, which are overexpressed on the B lymphocytes in non-Hodgkin lymphoma. And that's example of radioimmunotherapy. And same goes for this drug, iodine 131 labeled CTNT monoclonal antibody, that's being used for treating advanced lung cancer. And that's again an example of radioimmunotherapy. And it targets the intracellular DNA in necrotic tissue. And apart from this, we have this group of drugs, yttrium 90 level Dotatok or Dotatate, or lutetium level Dotatok, Dotatate, and these are used in treatment of neuroendocrine tumors, and it attacks these receptors we call as the somatostatin receptors, and these receptors are overexpressed in case of the NETs. And that's example of PRRT. It's called as peptide receptor radionuclide therapy. And we have this iodine 131 labeled MIBG, which is also being used for treatment of neuroendocrine tumors. And apart from these, we also have other local or regional therapies. Example, yttrium 90 labeled glass microsphere, or yttrium 90 labeled resin microsphere, which we call as Thera sphere or the SIR sphere. And these are widely used for the treatment of primary and secondary malignancies of liver, and by a process we call as radioembolization. And apart from this, we have P32, yttrium 90, rhenium 86, and gold colloids, which are also being used for treatment of therapy of malignant effusions or of ascites, and example of being intracavitary or intraperitoneum or intrapleural therapy. And last but not the least, we have yttrium 90, rhenium. These things are being used for treatment of rheumatoid arthritis by a process we call as radiation xenobectomy. So in this chart, we have seen a lot amount of drugs which are being pharmaceuticals being used for the TRT. So whenever I use the term TRT, that means targeted radionuclide therapies. I will use TRT for simplification. So next is I will talk about the ideal properties of the ideal therapeutic radionuclides. So the ideal radionuclides which are being used for therapy, it must have some basic ideal properties. First is that we will use for an ideal radiopharmaceutical to be used as a therapeutic agent, it must have abundance of charged particles. It means this radionuclide it must decay by means of alpha decay or beta decay process. It must not decay by gamma decay process. So that's the ideal one. Fine. And these are charged particles which are non-penetrating, and these are highly penetrating radiation. So for an ideal radionuclides to be used in therapy, it must be having a higher abundance of non-penetrating radiations like alpha particles or the beta particles, and it must not have penetrating radiations like gamma rays or the X-rays. And next is the energy of the charged particle. It determines how much amount of energy is going to be deposited in a given volume. and that we express by means of LET. That is, LET is equals to dE by dL, that is energy deposited per unit length of the track, and we express that is an kilo electron volt per micrometer. And for alpha particles, this LET is quite higher, but for beta particles, that's not as size as alpha particle. And the higher the LET of a specific radionuclide, the greater is the relative biological effectiveness. I guess Shuman Mishra from IIT Kharagpur has already explained how LET and RBE are related, so I don't need to explain this part again. And one more thing we should keep in mind, that if my radionuclide decays by gamma emission, that's also okay, but it must not decay by higher emission of gamma. But if it has gamma emission, that it can be used as theranostic agent. May be useful for imaging studies to demonstrate tumor localization or altered biodistribution post therapy. And beta particles have low LET values, and it RBEs unity. So. And these are a series of radionuclides which are used for the preparation of therapeutic radiopharmaceuticals. And example, yttrium-90, rhenium-188, holonium-166, p32. These are all group of pharmaceuticals, radionuclides, which are being used for preparation of therapeutic radiopharmaceuticals. And let's now explore these radionuclides in more detail, and with let us study some properties about these radionuclides now. So if we go and check out yttrium-90, so it has a half time of about 2.6 days. It means after every 2.6 days, its amount will be getting reduced by half. And it decays mainly by prominently by beta decay process by emitting an electron. And if you go and look at the energy of this yttrium-90, it has a maximum energy of about 2.28 MeV and a mean energy of 0.935 MeV. And the range of these yttrium-90 is about, these are in millimeters, 12 millimeters maximum range of this yttrium-90, and a mean range of 2.76 millimeter. And these are all nucleides. One thing we should keep in mind, that all these beta emitting radionuclides, it decays either by beta solely or a combination of beta and gamma. So those nucleides which are decaying by beta and gamma emissions, it can be used as theranostics. So beta will be used for therapy, and gamma for diagnosis part of view. So for imaging part of view, for example, rhenium, it decays by beta gamma. I guess iodine-131 is the most prominent example of it. Like we can use iodine for therapy also, and for post therapy imaging also. That's iodine-131, and that's maximum energy of iodine-131 is about 0.61 MeV, and the mean energy being 0.20 MeV. And this iodine-131 beta particles has a range of about 2.4 millimeter and a mean range of 0.40 millimeter. So we can see how these range changes, how this range changes for different radionuclides. So for yttrium-90, the range was quite higher, about 12 millimeter, and for iodine, the range is quite lesser. Okay. So, and then we go for these alpha emitting radionuclides, example, bismuth, astatine, rhenium, iodine. So example, bismuth-213, bismuth-212, astatine-211, these are all radionuclides which decays primarily by means of alpha particle emission. Example, I guess I have explained about astatine-211 yesterday in my presentation, that it decays by emitting 2 alpha particles in a split decay process, and it has a half time of about 7.2 hours, and it makes ideal for radio labeling to any monoclonal antibodies or any other things. And if we go and check out the range of these alpha emitting radionuclides, we can see their range are in microns. But if we go and compare the range of these beta particle emitting radionuclides, their range are in millimeter. So now we can understand that beta particles have higher range, whatever the energy, whatever the particle be, but still they have higher range. But alpha particles have a lower range, and that too in microns or in nanometers, their range lies. And one factor is very important for therapy part of view, because suppose we have a tumor over here, and some radionuclide has bound over here, but the time course of radiation, it depends on one factor, that is we call as effective half-life, T effective. Because if the T effective is less, it will bind obviously, but it will go and drain out. It will go and excrete from the body very easily. So the time course of irradiation is very less. And again, if the time course of irradiation is very less, then therapy is not possible. But because therapy is not done, because you have irradiated for a small time, so damage cost is very less. So all those damage, whatever you have caused, these get repaired soon. So that's of no use. So maybe you have given therapy, but as the T effective was very poor, so therapy was of no use, and you can say tumor recurrence. So that's we call as a failure of therapy. And again, if T effective is very large, and it will keep on binding for a longer time, so it will go and cause normal tissue toxicity also. That also we don't want. So we have to go and think about it, some intermediate half time or T effective half time, so that this irradiation time is sufficient for tumor killing. Fine. So now next topic, we'll talk about some two basic important effects, which is important in nuclear medicine perspective, which we call as the crossfire effect and the bystander effect. So now when you go and look at a tumor, it's not always compulsion the tumor will have an uniform distribution of receptor. Like for example, it's a tumor which express CD20 receptor. So it's not always essential that this tumor will have equivalent or it will have a great distribution of CD20 receptor around the surface. There are cases where this tumor distribution is non-uniform. So for example, like this part of the tumor, it has a good distribution of the CD20 receptors, and in this part, it does not have a good distribution of the receptor. So what it means, more amount of radionuclides will bind at this region, and it will go and irradiate this region higher, and it go and it will not irradiate this region higher. So this region will be spared post therapy. But if something is spared post-therapy, that's again a failure, because these are a clonogenic cell. It will go and replicate again and again and again, and at the end you will get up the same tumor once again. So that's again a failure. So whatever therapy goes in, so we have to irradiate entire tumor volume uniformly. Otherwise, we cannot expect that we will get a response post therapy. And that's the main clue for this presentation. So what actually goes on, that we call an effect which we call as a crossfire effect. It's not possible that every tumor volume will have an equivalent distribution of receptors, and it will not irradiate uniformly. But what about those cells which has not been irradiated? They won't die. See, if they won't die, they will again grow back and from the main tumor again. So that's a failure of therapy. So by means of these two effects, we can see a drastic decrease in cell numbers post irradiation. And that's we call it the crossfire effect and bystander effect. So what goes on, for example, this cell has the radionuclide bound to it. So this cell will go and definitely go and irradiate this cell. But what about this cell? This cell has not been exposed to radiation. But because of the beta particles which have longer range, it will go and strike off. It will go and crossfire this cell too. And this cell now also have the radiation over here. And that's the beauty of this crossfire effect, that those cells which has not been irradiated, or those cells which have non-uniform distribution of the radiopharmaceuticals are also depositing energy because of this crossfire effect. Fine. So, but still there might be some cells which has not still received radiation. Those cells must die. And those cells die because of an effect which we call as bystander effect. So what goes on, for example, this cell, it has crossfired these beta particles to this cell. So these cells have deposited energy, they will definitely die. But what about this cell won't die because they have not received radiation doses. But still this cell dies because this cell which has now exposed to radiation, they secrete some signals. And these signals, which we call as bystander signal, it goes and kills the cell. So these cell signals can be any signals like apoptotic signal, which lead to program cell death of this cell, and it can be many more signals like any others, and it can be any signals which can lead to cell lethality, and that's what we call as bystander signal. And these signals are being emitted from the irradiated cell post. These signals are being emitted from these irradiated cells and to those cells which has not been exposed to radiation. So now you might have known that the one fact that we have tumors can be of different sizes. It can be a macroscopic tumor. It can be a microscopic tumor, or it can be of different shape and sizes. So, for example, if we have a microscopic tumor, for example, a small size tumor, and if we want to treat these disease, so which type of radionuclide we have to use, whether we will go for alpha particle emitting radionuclide or beta particle emitting radionuclide? Answer is we have to go for alpha particle emitting radionuclide. For example, if I use beta particle emitting radionuclide, go wrong over here. So that's a small tumor over here, and that's my beta particle emitting radionuclide. So we know that the beta particle range are higher. We can see over here beta particles have a higher range, and that too in millimeter. So what it will do, it will go and deposit energy over here, over here, over here, over here. So we are not getting effective radiation dose absorbed in this tumor volume. So tumor volume is not getting enough radiation dose, so hence it won't kill the small volume of tumor. But now if I go and use an alpha emitting radionuclide, so it has a lower range, as we can see from here, in this, it's in microns. So it will go and deposit energy over a small region, small volume, and lead to effective cell energy deposition in this volume, cause molecular lesions, double strand breaks, many more things, and cause the cell death. And that's how these, for treatment of microscopic disease, we always have to go for alpha emitting radionuclide because they have a shorter range. Fine. And if you have a combination of microscopic and macroscopic, go for alpha and beta emitting radionuclide in combination. You will by alpha you will go and treat the smaller one, and by beta you will go and treat this larger one. And those radionuclides which decays by emission of OG electrons or any other low energy electron, example iodine 125, it decays by emission of an OG electron having energy of 0.40 kilo electron volt. So if this energy of 0.40 kilo electron volt, it get deposited on the nucleus of the cell. For example, there's the cell's nucleus, it contains DNA. And if this OG electron, if this iodine 125 get localized in the cell's nucleus, so whatever electrons will be deposited, it will deposit on the DNA directly and cause double strand damage, and hence your cell will die if it cannot repair the damage. And that's about the OG electrons and how it can be used for treating a variety of tumors. So now we'll talk about how these therapeutic radionuclides are being produced, and I guess someone has already taken up this part, how radionuclides are being produced through cyclotron, through generators, through reactors. I guess these things have already been covered, so I will just have a glance about these things. So whatever beta emitting radionuclides we produce for therapy part, these are all man-made. So it means they are either produced using nuclear reactors or they are produced through radionuclide generators. Fine. And radionuclides which are decaying by means of beta emission, they can be generally produced either in a reactor using the fusion of uranium-235, or by the neutron capture reaction, or by neutron capture reaction. So and these reactions can be of two different types. It can be an gamma reaction, or it can be an p reaction. So neutron comes in, makes a daughter and emits a gamma ray photon, or neutron comes in, neutron gets captured, emits a daughter, and a proton gets liberated. These two reactions can be used for production of the beta emitting radionuclides, or by means of the fission of uranium-235. Like we can also produce iodine-131 through uranium-235 fission. And apart from these, we can for alpha emitting alpha emitters like astatine. If we go and see how astatine is being produced, astatine 211 is produced by a process in which what we do, we irradiate the bismuth target with alpha particles, with a beam of alpha particles, which has energy about 28 to 28.5 MeV. And after irradiation of this bismuth target, it leads to production of astatine 211 and emission of 2 neutrons. And this astatine 211 can be recovered from this target and can be used for the other processing step to radio label astatine with any other molecules of interest which is specific for a given tissue or for a given receptor which is being used for therapy. Fine. So these are the ways how we can produce the radiopharmaceuticals which are being used for therapy part of view. And these are, I will just give a glance view because these have been covered anyways. So for example, for reactor produce, so example, how do you produce iodine-131? So by a fission process, uranium-235 absorbs a neutron. It get unstabilized. It fuses to make it makes fission products and also iodine-131. Or you can produce iodine-131 through bombarding tellurium with a beam of neutrons, and tellurium-130 get converted to tellurium-131. And by then after tellurium 131 through a beta minus decay goes and from iodine 131. And that's a simple process how you produce iodine 131. Sorry, I'm taking a small break. Okay, next is about P32. So P32 can be produced through two processes, as I've told before. Through neutron capture reactions, we can produce radiopharmaceuticals for therapy. So, and this capture reaction can be of two different types, N P reactions or N gamma reaction. So what goes over here? So phosphorus 31 captures a neutron and converts to P32 by emitting gamma ray photon. And that's how we produce P32. Or sulfur 32 captures a proton, converts to P32 and emits a proton. So these two reactions can be possible. Either through NP reactions or N gamma reactions, you can go and produce different type of radiopharmaceuticals. So these are similar ways, but we can see all the reactions which lead to production of these given radionuclides. These are all through NP reactions or N gamma reactions, or some of them are through fission process. And cyclotron produces astatine. I guess yesterday also and today also I have told by bombarding bismuth target with a beam of alpha particles having energy of about 22 to 25.5 MeV, you can go and produce astatine 211. So these are all by means of this process. Cyclotron based produced are astatine 1211, which decays by emitting 2 alpha particles, and that's used for alpha therapy. And generator produced are these ones, so like strontium, yttrium generator, and so on and so forth. So the radionuclides which are being produced by means of the fission process, uranium-235 fission or anything else, or by the radionuclide generator are usually very preferable for preparation of radiopharmaceuticals. Why? Because they have higher specific activity, that is activity per unit mass. Fine. Now we'll go to talk something more about these therapeutic radiopharmaceuticals. So these pharmaceuticals can be simple molecules. It can be like iodine 131 or strontium 89. These are simple ions. Or can be some complex molecules in which you can see like samarium EDDMP, which is being used for bone pain palliation. This samarium is at the center, fine, and it forms multiple coordinate bonds with N and oxygen over here, and these 5 Na are the counter ions. So that's quite complex structure also. So, or it can be like structure. If you go and see the structure of MIBG, that's the structure of this MIBG, and there's the benzene ring and there's the meta position. So that's why we call this meta iodobenzyl guanidine. And that structure of DOTA-TOC, we can see yttrium-90 sitting at the center and has formed multiple coordinate covalent bonds with oxygen, nitrogen, and everything else. But why? And that's the peptide sequence over here. And this peptide is specific for these SSTR receptors. It's not yttrium, neither this chelating molecule, but rather these particular sequence of peptide which is critically important for binding to a SSTR receptor. And as a whole, this entire complex is stable. And if you go and label yttrium with this peptide, this radio labeling is not going to happen. So that's how we are designing chemistry sequence and chemistry steps for making this therapy possible. And finally, we have like yttrium-90 microspheres. We have yttrium labeled to some spheres, and these are glass spheres or anything resin spheres, and these are used in treating different type of liver mets by a process called as radioembolization. So we have seen how different structures looks like of the pharmaceuticals. Some basic structure we have those seen, but one factor is very important for therapy. That is what we call as tumor localization. For example, if I have a given tumor and if I have a very good drug, and this drug don't even localize the tumor, then it's of no use. So it will irradiate the tumor only when it localizes the tumor. Otherwise, how can it irradiate? So one factor that is very important for us to understand, that is we call as tumor localization. If our pharmaceutical don't even localize to the tumor, then how can we expect the therapy? Therapy is only possible when your pharmaceutical will be localized to the tumor. And how the pharmaceutical will localize, it depends on some properties, and it also depends on the route of administration, like you are giving intravenously, intraarterial or oral or anything else. Fine. So if you go and take iodine 131 through oral route, you will get the uptake in the thyroid follicular cells, but through intravenous route you will never get it. So that's the main way, that how much tumor localization you are expecting out of it. It depends on how your how the route or how you are giving the drug, or that is through which route of administrations you are giving the drug. And apart from these, the ideal physical and biological properties of pharmaceuticals, and the ideal physical process and the ideal property of a therapeutic radiopharmaceutical should be such that it should deposit a large amount of radiation in the tumor with a minimal dose to the normal tissue. That's the main thing which you want out of therapy: higher dose to the tumor and lesser dose to the normal tissue. That's what an ideal pharmaceutical and ideal radiopharmaceutical must have. If you go for radiation therapy, also radiation oncology, also they also want it. You want to irradiate higher dose to the tumor and less to the normal tissue to prevent side effects or normal tissue toxicity. And same goes for these therapeutic radiopharmaceuticals. So ideal property should be such that you deposit larger absorbed radiation dose in the tumor and a normal dose to the normal tissue. And if we want to achieve this thing, to higher dose to the tumor and minimal dose to the normal tissue, we must use the radionuclide appropriately. Firstly, because if I want to treat thyroid, I must use iodine-131, not iodine-131 MIBG, because this will go and treat NAT. But if I have to use appropriate radionuclide for a given disease, and this nucleide must be in a suitable chemical form with optimal specific activity and also an optimal route of administration. And if I go and follow these steps, then it will lead to selective uptake in the target, and it lead to elicit a therapeutic response. And that's the main diagram which you can think in mind. So we have to use an appropriate radionuclide, and it must be administered in a suitable chemical form with optimal specific activity and by an appropriate route of administration for selective uptake in tumor and to elicit a therapeutic response. And there are different ways by which your therapeutics or therapeutic radiopharmaceuticals get localized in the tumor. And example, metastron or Quadramet, which we use for bone pain palliation therapy. So these are deposited on the bone cells in response to the osteoblastic activity, which are increased in the metastatic lesion in the bone marrow. So now we have talked a lot about these things, and and also before we have talked about the conjugated radiopharmaceuticals. So what we know about conjugated radiopharmaceuticals? So that's a conjunction of radio metal with a carrier molecule, and this carrier molecule, it directs this entire complex to a given tissue location, to a given target location. So this carrier molecule, it must have some properties, and now we are trying to understand some properties of this carrier molecule, which is critically important for us to understand. So, and how much uptake will be there, how much pharmaceutical will be taken up by the tumor, it depends on the interaction between the chemical, between the ligand and the receptor. Fine. So the specific tumor cell uptake of a pharmaceutical, it depends on the chemical and biological properties of the ligand. So for example, first factor is that the chemical carrier or the ligand or the vector, it must be biological specific and it must have in vivo stability. So what it means basically, we must be understanding what is biological specificity, what is in vivo stability. For example, now we have a cell over here, and it expresses two receptors, CD20 say and CD40 say. And we have two chemical carrier, or we have two ligands, a ligand A and ligand B. And CD20 is overexpressed in disease. Fine. So this ligand B, it binds both to CD20 and CD40. And ligand A, it binds to only CD20. So which carrier molecule which will you use for therapy? Definitely A, because it's more specific for my diseased one. If I would have used B, then apart from treating cancer, I'm also going to cause some complications. So I have to use those carrier which is more specific. So it must be biologically specific, and it must have in vivo stability. Once inside the bloodstream, it must be stable enough to go and bind over here. So it also, second is, it must have affinity to the binding site. If it does not have affinity to the binding site, how will it bind? If it has lesser affinity, it will come over here because it has specificity, but it won't bind. It will just slip away. So that's not the case which you want. So it must have specificity and high affinity. Secondly, this complex which is being formed over here, that is, we have a ligand, we have a receptor, and it forms a ligand receptor complex. And this complex must be stable enough. If it's not stable, this ligand receptor complex will break down to ligand and receptor. So it has bound actually, but it has now again distorted out. So we are not irritating the tumor again. So stability of the complex is very important. So the time and the stability determines the time of irradiation. More stable complex, more time of irradiation. Lesser stable complex, lesser time of irradiation. And one thing again we should keep in mind is one factor which we call is is not to lose biological specificity. For example, we have some radionuclides, say yttrium-90, and you are binding this yttrium to a complex, to a ligand. Fine. So this ligand basically is specific for, suppose, CD20, say. But once I ligate this ligand to my yttrium-90, this may not go and bind to CD20. It might lose its properties because these are chemical bonds basically. So when you ligand is alone, so it is very free to go and do its job. But once you go and ligate these ligand to some radiometal, so there is a bond formation between this radioligand, radiometal, and the ligand, and this bond can in some ways, like in some stereochemical way, can inhibit this formation of bond between ligand and CD20, and in some ways this ligand, this yttrium-90, can disrupt ligand from binding over there. So we must not use those ligands which actually after radioligation loses its specificity. So only those ligands we have to use which is stable even after radio labeling. Fine. So those carrier molecule we'll be using for therapy which is stable even after radio labeling too. And these are some properties which should be kept in mind while we go and radio label these things with a given radionuclide. And these are different mechanisms by which these radiopharmaceuticals or radiopharmaceuticals localize to the tumor cell. Example like DOTA-TOC, DOTA-TATE, yttrium-90 level, DOTA-TOC, DOTA-TATE, lutetium, DOTA-TOC, DOTA-TATE. These bind to the highly expressed SSTR receptor. And these SSTR receptors are highly expressed on the NETs, neuroendocrine tumors. So by this receptor ligand interaction, these yttrium-90 level binds to over there, and after it irradiates the tumor cell, and hence this hence the tumor shrinks in size post irradiation. Like iodine-131, it enters inside cell by means of the sodium iodide symporter. That's an active process in which these iodide ions are being pumped from outside to inside through this transporting protein. And once this iodine-131 is available inside, it goes and emits beta particles, and hence it lead to effective cell damage. And there are other ways too, like antibody antigen interaction over here, like yttrium-90 level. This drug interacts with CD20 receptor on the B cells. These are different ways of interaction of these drugs with the cell surface, and these are different mechanisms by which your pharmaceuticals localize on the tumor. Fine. And now we'll study some important characteristics of the ideal therapeutical radiopharmaceutical. So first is that I have already mentioned that it must have high specificity and affinity for tumor cells. So that's my tumor cell, and that's my normal cell. If my pharmaceutical does not have specificity for this tumor cell, then it cannot treat it. So it must have high specificity to it. Otherwise, how can it treat it? And also high affinity also. Second is in vivo stability. It might have in vitro stability, but inside body system, it might lose its stability. It might not go. It might not be stable. It might not be specific enough now. So it must be in vivo stable with minimal metabolite formation, and it must have rapid blood clearance and also rapid targeting. It should not be like that. I have injected the pharmaceutical now, and after 3 days it will go and act. I cannot expect this. It must have rapid targeting also, and also it must retain for a significant amount of time to elicit a therapeutic response. And fourthly, it minimal uptake and retention by normal cell. It's not the case your metal will go and bind to normal cells, so it will go and cause normal tissue toxicity, which you again don't want. And it must have minimal hematological toxicity and some toxicity, also acceptable toxicity to liver, spleen, and kidney. And last but not the least, it must not induce radiation-induced biological effects. So for example, I am going to use these pharmaceutical for treating cancer, but in turn I'm inducing cancer again. I'm inducing secondary cancer. It must not be the case. So whatever applications I'm using for, it must go and do that job only. It must not go and induce mutations, transformations, and many more things. So it's a lethal job. I'm using for treating cancer, but I'm inducing cancer. That's not the case. These are the characteristics of ideal therapeutic radiopharmaceuticals, which we should keep in mind. So we are approaching the end of our presentation. So these are different type of monoclonal antibodies which are being used in radioimmunotherapy. So these are murine monoclonal antibody. These are chimeric monoclonal antibody. These are humanized monoclonal antibody. So we can see over here in case of murine, that's both the chains, both heavy chain and light chain, are of mouse origin. That's the fragment of antigen binding. That's fragment of constant binding. That's FB region. So fragment of variable region, and this region goes and bind to antigen. And these are humanized antibody. That's entirely derived from human source. That was from mouse originated. That's human originated, except for the CDR. What is CDR? The complementary data binding region. And what is chimeric one? The chimeric is a combination of both the murine and the humanized. Fine. And these are fragments. So that's the intact antibody. These are fragments. Which fragment? These fragment. Am I audible?
Yes, you are.
Yes, you are audible. Please continue.
Okay. So these are the single chain fragment. We have seen that's the intact antibody. And these are the intact fragment. These are fragments. Fine. And these fragments are also being used in our radioimmunotherapy. You can see that's a single chain FB fragment. And that's the same structure over here, but main difference lies the fact that that's a disulfide stabilized. We are stabilizing the structure by means of a disulfide bond. And the third one we call as antibody. That is, both these are all single chain FB fragment, but these are stabilized, or it has formed dimer through these non-covalent interactions. And these antibodies have a higher molecular weight compared to these single chain fragments. So that's because that's a dimer. Fine. And one of the antibodies which have been used for treatment of for RIT was the murine antibody. So the first generation antibodies which are being used for radioimmunotherapy, where these murine antibodies which are being used for radioimmunotherapy at the initial times. And these are a series of drugs which are monoclonal antibodies which are being used for therapy of. Please mute yourself, please. Okay, so these are a series of drugs approved series of drugs which have been in market since 1992. So that's indium level OncoSync, which is being used for ovarian and colorectal cancer. And the type of the antibody, monoclonal antibody being used is the murine IgG type. And these are other drugs too. But we can see that like yttrium level Zevalin and Bexar, which we use for treating the non-Hodgkin lymphoma, and indication being it must be CD20 positive. So these group of drugs are given to those patients who are CD20 positive and with low-grade lymphoma. And these drugs go and bind to these overexpressed CD20 receptors on the B lymphocytes. And one thing which you can observe in this chart is that the type of the IgG being used, and most of them are IgG1 subclass. Fine, all of them are murine, or like it can be murine IgG or humanized or chimeric, but all of them have a majority of them have IgG1 subclass. So IgG has a different subclass. It can be IgG1, IgG2, 3, 5, and so on and so forth. And IgG1, IgG2, IgG3, they have a defined half-time in blood. Example, IgG1, 2, 3 have half-time of about 21 days in blood. IgG4, 5 have 2 or 3 days in blood. So they don't have, maybe they are all IgG molecules, but their properties are not similar. And out of these, IgG1 is very important. Is very potent for using as for using as a radioimmunotherapy. So because it can induce multiple other pathways like complement dependent cytotoxicity, because it induces other pathways which can lead to enhanced cell killing. Apart from radiation therapy, apart from the killing by means of radiation, it also induces other pathways like complement dependent cytotoxicity or antibody dependent cellular cytotoxicity or many other pathways and lead to effective cell killing. And now we'll talk about some more fact about this antibody. So first is about size, penetration, and clearance rate of antibodies and fragments. So if we go and check out for intact antibodies, like for this one, which is intact, which has both constant and which has both like for this one, it has as the molecule grows bigger, the residence time is also higher. And this molecule, it takes about 2 to 4 days for optimal tumor to non-tumor ratios after 2 to 4 days post-injection. So if you go and inject this antibody today, after 2 to 4 days, you can see an optimal tumor to non-tumor ratios. So it takes more time for this thing to happen. But in contrast, if I go and use some fragments like single chain FB fragments or any other things, so it results in much faster blood clearance and also very quicker tumor to non-tumor ratios. Fine. And if you go and see that for intact one, they have a larger molecular size, about 150 kilodalton, and for fragment it is very less. But for antibody which is intact, it has the highest tumor uptake. But it takes higher number of days for getting this uptake done, about 2 to 4 days. But for fragments, the uptake is very quick. Tumor uptake is very quick, but it takes hours. But and also it takes for single chain fragments, the tumor uptake is very less. For example, that's a tumor. So an intact antibody, for example, it will take 100 number of antibodies, but for fragments it will take 30. So uptake is less, but it takes very quickly. But uptake is very high, but it takes more time to go for the same. Now we'll move forward to our receptor binding peptides. So peptides, we know what are peptides. So these are small amino acids. These are the small amino acid sequences. So peptides can be of natural or synthetic origin, and they go for a variety of biological interactions. It can be peptides can be hormones, protein, anything else. So, and these peptides bind to specific binding sites on receptors or on cell membrane or within the cell in order to initiate specific actions and many more things. And also we can see that some peptides are overexpressed in some disease state. Example, SSTR receptors, which are expressed morely on disease state. And these peptide agonists are quickly metabolized by aminopeptidases and many more things. So that's not our issue. And these are the peptides which are overexpressed in tumor. Example, somatostatin peptide is overexpressed in a neuroendocrine tumor, small cell lung cancer, breast cancer, in monocytes and lymphocytes, and the receptor subtypes is SSTR1 to 5. And we can image these things by means of using technetium or indium or adenine-123 octreotide analogs. Fine, like yttrium-90 like DOTA-DOC-DOTA-T can be used for imaging the somatostatin receptors. Like in one more peptide, bombacine, which is overexpressed in prostate cancer, breast cancer, and this group of cancer, and we can using technetium level bombacine to image this thing. So these are group of peptides which are overexpressed in this group of diseases. I will share the slide to you. You can go and see which peptide is overexpressed on which group of tumors, and how to image those things. That's your corresponding agents which can be used to, which can be radiolabeled to something else and to go for imaging. And that's the original sequence of original peptide sequence of somatostatin, and that's what we are trying to copy. It has phenylalanine, tryptophan, lysine, threonine, and one we can chemically make similar peptides. Example, we can make DTP octreotide. It also has similar sequence like it has like phenylalanine. It also has tryptophan, but it has deep tryptophan, lysine, threonine. So we can chemically make similar peptide sequence and then can go for imaging part of view, and I can go and tag this with some radio metal and can go for using for imaging or therapy based on what type of emission the particle has. If it go for alpha, beta, then we can go for therapy, or gamma for imaging, or combination of both of them for theranostic. So That's all for today, and hope you like this presentation. And our next session is on computer science for nuclear medicine and image reconstruction. And if you have any question, please write it down in the chat section. I will love to answer to those questions if I can. Thank you so much.
Thank you, Biprojit, for giving us such a deep understanding over this topic. Any questions?